You either understand it today or you will never. When I was in my second and third year, I did not understand it. I went to the internal medicine during the fourth and sixth year, and I had no idea what they were talking about. And it was a gap in my understanding of cardiovascular pharmacology. So please focus today, follow the sequence, and if you've got any questions, please stop me. But before we get to the pharmacology, I'd like to present something that might be emphasized during the pharmacology lab next week. Okay? Which is a case. A case about our friend Khalil. So Khalil, who is a 35-year-old guy, reported to the ER, or came to the ER, reporting sudden fainting while playing football. And he lost his consciousness for about 2 minutes during that attack. Now, thereafter, during that attack, his friends reported that he had no convulsive or spastic movements. And this lasted for only 2 minutes, and then he was conversant and able to walk thereafter. Okay? So he came to the ER walking. Right. Now, his family history was unrevealing. There was nothing important. And his past medical history also was negative. He's just a 35-year-old guy. He's single, office worker, he's non-smoker, he's non-alcoholic. Everything looks fine. He had no medications history, no allergies. And when we performed the physical exam, his heart rate was 92 beats per minute, and it was on regular rhythm. His respiratory rate was 16, which is normal. His blood pressure was 125/65, which is normal. Temperature was normal. O2 sat was normal. Lungs normally auscultated clear fields. And the heart, regular rate, rhythm, normal S1 and S2, and no murmurs. And the neurological exam was normal. But what's the differential diagnosis? تعرف شو يعني differential diagnosis? يعني what do you think of? What could be the reason for that attack for about 2 minutes of the loss of consciousness? Give me just common sense. طبعا by the way يعني بما انه المحاضرة cardiac arrhythmia, it's cardiac arrhythmia بس. Yes, go. Good. Okay. Nice. We did the glucose check and his blood glucose level was normal, but that's good thinking. What else? Something important. What? Heart block. يعني cardiac arrhythmia خلينا نحكي. طيب احكي. ما احنا حكينا arrhythmia. Atrial ventricular block واللي بدك اياه. Something important in such cases, which is common also at this age. Me? No, 35 years old. حكيتها. الأيونات والذرات والنواة. لا شغلة important على هيك عمر yes. Excessive what? Activity. يعني posture hypertension وداخل وجع. ليش؟ Yes, seizure. This is something you have to mention. And one of the differential diagnoses in such case is seizure. And this is the first thing you have to think about, actually. And that's why I focused on the neurological exam. Neurological exam was totally free. But since this lecture is about cardiac arrhythmia, I want to focus on cardiac arrhythmia as a major cause for such cases. And the reason I'm presenting this case here is that it's not uncommon to have the first presentation of cardiac arrhythmia as syncope or fainting or falling down while having some sort of exercise, okay? And the second thing is that it's not uncommon to have your patient presenting to the ER having everything that looks normal, okay? So your job will be to determine what's next, how to define what's going on, and what to do next. And this is what we're going to answer at the end of this lecture. So cardiac arrhythmia. Let's start by the basics and move on to the relevant points related to cardiac arrhythmia. And starting with the structure of the heart, we have to focus on three important parts of the heart that lead to the conduction of the signals through the heart, which are the SA node, the AB node, and the conduction system. And nice enough, what we have is that a signal starts somewhere, which is commonly in the SA node, and then travels automatically without any kind of interference from us into the whole heart, okay? Now, since we are talking about signals, we mean electricity. And since we're talking about electricity, it's worth it to look at the membrane potential and how these things change. And this is what Professor Muhammad Jafar explained to you in his lectures, physiology lectures. But I want to go over these parts because they're going to be very, very critical for your understanding of the pharmacology. Just a reminder. This is the action potential, what we have actually in most ventricular cells, right? This is how it looks like. And the different colors mean that it has different phases, right? So, let's have our key for this figure. Any increase in the potential means depolarization, which means what? Activation. And any decrease means repolarization, which means going back to the resting rhythm or resting potential. So, starting with the phase 0. What is phase 0? It's a rapid depolarization. What's responsible for that? Okay, so the important thing here is to understand that what we're dealing with, electricity, is related to ion channel transport, right? And the important type of channels during phase 0 are the sodium channels. Now, do we have a characteristic for these sodium channels in the ventricles? The fast sodium channels. This is important to say. Fast sodium channels are the ones responsible for such rapid and abrupt increase in potential. And as you can see, these fast sodium channels will move sodium from the outside into the inside. But they suddenly stop. Why is that? Because these fast sodium channels, they're not only fastly activated, but they're also rapidly inactivated. When we say inactivated, they stop, which means what? The pore that's, it's not closed totally. One of the pores is closed, and that's why we call it inactivated. At later stages, it's going to be closed, which means the outside and the inside will be totally blocked. Okay? Now, after that, a small phase of repolarization happens, right? And what's responsible for that?
Potassium.
Exactly. It's the transient potassium current after the inactivation of the sodium current, okay? And potassium, as you can see, is the one that moves it from the inside into the outside of the cell. Are we good? Mm-hmm. And as you can see, it just stops abruptly. It's not for a long time. It's just minor, okay? And that's why we call it partial repolarization. It's not full repolarization, which means we did not get down to the resting membrane potential. Right. Why does it stop here? Because there's something else that gets open and this gets inactivated.
Calcium.
Okay. This is the phase 3, or phase 2, sorry, in which we have another type of channels that get open, and these are the voltage-gated calcium channels. And as you can see, the membrane potential does not change that much. And that's why this phase is called what? The plateau. Now, calcium again, just like sodium, moves from the outside into the inside. Now, the nice thing about this is that we have something like an equilibrium between the influx of calcium and the efflux of potassium. Okay? And that's why we have a plateau. Just remember these phases. Yes? Sodium and air? Now, the sodium channels are inactivated at this phase, which means what? They're not totally closed, but they cannot let any sodium in. And the other thing I'm going to mention is that it's related to the SA and AB node. Okay? You will see in a minute. But just remember, for ventricular plateau, it's the equilibrium between the influx of calcium and the efflux of potassium. Okay? And the other thing is that, as you can see, I'm showing different kinds of, or colors of the channels, which means the potassium channels that were open during phase 1 are different from the ones open during phase 2.
هي الفكرة إنه بالبلاتو بتفتح السلو صوديوم كالسيوم شانل، هيك أخذنا، وهي سلوينج، هي بتاخذ وقت حتى إنها تفتح، بتضل مفتوحة لفترة طويلة، بيكون فيها influx of calcium and sodium.
تمام. In the ventricular muscles, we mean the calcium channels. Let's leave the sodium for the SA and AB node. Just wait a minute. It's important. Now, the next phase is phase 3. And as you can see, this is the full repolarization, right? Now, what's responsible for that? Of course, it's the potassium current, and the calcium channels will be closed, and the potassium will continue to efflux out of the cell, and that leads to the full repolarization. Right. The last phase is the phase 4, which is responsible for what? Setting the resting membrane potential. Okay? And what governs that? It's the sodium potassium ATPase pump, which lets sodium out of the cell just to get the equilibrium back into the normal status, and potassium in. And that's on the expense of ATP. And that's why this is an active phase. طيب. ماشي. This is the action potential of the ventricular muscle. And what I'm showing here is that it corresponds to the waveform of the ECG. This is what we can measure on regular clinical practice. It's the ECG. We cannot measure this regularly. Okay? So in a patient, if I want to understand the ventricular action potential, I have to look at what? The ventricular or the ECG waveform. Which means another thing, that every part of this is represented by something within the ECG waveform, right? But starting with this, phase 4, which is the resting membrane potential, as you can see, it's represented by the P wave. Why is that? Now, you have understood that P wave corresponds to what? To the atrial depolarization, right? And that's why it corresponds to phase 4 of the ventricular muscle action potential, right? We do not have a good representation of the atrial muscle action potential, so we represented the ventricular muscle action potential. So before the depolarization of the ventricle, the atria should have some sort of depolarization. And that's why we have the P wave representing phase 4 on the ventricular muscle. Did you understand? Phase 4.
Phase 0, depolarization.
Now, phase 0 is what?
Depolarization.
Is the ventricular depolarization. What could that represent on the ECG waveform? The QRS. Exactly. So the QRS, which represents the ventricular contraction or the ventricular depolarization in much accurate words, represents phase 0 on the ventricular action potential wave. Okay? Now, what's left of the ECG waveform? The T. And the T represents what? The repolarization of the ventricle. What about the atrial repolarization? It's blocked. We cannot see it here, okay? Because of the huge potential of the QRS, okay? Now, what's the phase that represents the repolarization in the action potential wave? It's phase 3, okay? And that's why when we have the T wave, it's represented by the phase 3 in particular, which is the ventricular repolarization. Why am I showing this? Because it's important. If I ask you, there's a drug that inhibited the repolarization, how does that translate into the ECG waveform? You just think that phase 3 is represented by the T wave, okay? And anything that affects phase 3 will affect the potential or the level of T wave or the rapidity at which T wave occurs on the ECG itself. Did you get it? ضعتوا ولا لسه؟ طيب. The other thing which you just traced several times is the comparison between the ventricular action potential wave and the nodal, which means the SA, and the AB nodal wave of the action potential. And as you can see, they look totally different. What are the differences? Number one, it's the resting membrane potential. Okay, so the ability to get to the threshold is much more readily available for that. And the other thing is that we don't have a plateau, so we don't have mainly phase 2. What we have are phases 0, 3, and 4. Okay? And the third thing is the difference at the look of phase 0. While phase 0 in the ventricular and atrial action potential is something of an abrupt potential, it just gets up. In the SA and AB node, it's more steep, it's more gradual. Okay? Which means what? Physiologically, how does that happen?
Slowly, not rapidly.
Yes? Wait. The important thing is to say that AB and SA node, they do not have fast sodium channels. Okay? So since they don't have fast sodium channels, something has to replace that to get to the depolarization level. And these are what? The spontaneous and slow sodium and calcium currents. Okay? And that's what Dr. Muhammad, I guess, mentioned here. The sodium and calcium currents are the ones that are responsible for the depolarization phase of the SA and AB node. And as you can see, they are slow and spontaneous, which means what? We do not need to have too much stimulation. The continuous influx of these ions will get the cell into the level of threshold and then depolarization. Just remember that when we talk about pharmacology, because it's important. Right. If we go back to our key figure, which is the different parts of the electrical conduction system within the heart. If I want you to give me one single word to describe each of these parts, what would you say about the SA node?
Pacemaker.
Pacemaker, which means what? Automaticity. The major feature of SA node is the automaticity. Right. What's the major feature of the AB node? Delay. Exactly. And I'd like to call it a delay and a relay station. Which means what? It just gets the signal, delays it for a while, and then relays it into the other parts of the conduction system. Okay? So it's a delay relay station. And then what about the other parts of the conduction system? What's their major function? Just conduction. Okay? Just conduction. They do not control any of the above features of the conduction system within the heart or the transmission of the signal through the heart. Right. Now, if you want to describe or explain the pathophysiological mechanisms of arrhythmia. What do you need to say? Just go to this key figure and look what could happen abnormally, right? So arrhythmia is something that happens wrong within these major features of the electrical conduction system. So cardiac arrhythmia could be related to bad automaticity, right? But what do we mean by bad automaticity? Exactly. So the first one is rate. We will get to your point. Rate. The automaticity of the heart has an abnormal rate, which means what? It's either increased or decreased. Okay? So it could be a tachy or bradycardia. The other thing about it is the origin. Okay? The origin of the automaticity features of the heart could be right, which is what? Within the SE node, or could be on other parts. And that's what we call extranodal. Okay? Now sometimes you will have a nodal tachycardia, a nodal bradycardia, or extranodal tachycardia, extranodal bradycardia. So you have to do this crossover. But it's simple. Look at the major features. Automaticity is the first one. What could go wrong? It's either the rate or the origin. What else? The conduction itself, right? What could go bad in the conduction system? First, it's the rhythm. Okay? The conduction should have a rhythm. It should originate from somewhere and move to another place, which is the delay relay station, and then move throughout the system or throughout the heart. Okay? The rhythm could be abnormal. So which means what? How do you translate it into clinical terminology? It's either regular or irregular. And what else? We go back to the rate or velocity of conduction, which could be delayed, could be increased, or could be blocked. There is no conduction at all. So do the crossover, and you will find that we might have a regular, okay, a regular nodal tachycardia. Okay. Do you understand now the terminology, how we got into these levels? But it's not something to memorize, it's something to understand. Go to the basic features of the heart, the conduction system. The major features, just say it could go wrong, and what could go wrong in these features. But we want to treat these abnormalities. And if I want to ask you what could be the most important way or mechanism of stopping arrhythmias pharmacologically. Yes. Since we said this is an electricity thing, and since we said that electricity is related to ion transport, how could I block these things? Just block the channels. And this is what scientists have done over the years. They just came up with drugs that will target certain types of channels within the heart, and they could block these channels and change the electricity and conduction within the heart. Right? Now, the problem, the maze with antiarrhythmic drugs is that people were unable to classify them. Okay? Until, I guess, 1970, when we have, that's what we said already, a new classification which is not totally perfect, a classification of antiarrhythmic drugs called the Vaughan-Williams classification. Okay. If I want to classify them in an easy way, we will have a class that will target the sodium channels, a class that will target the calcium channels, a class that will target the potassium channels. And then we enlisted them or enumerated them. So we got class 1 antiarrhythmics that block sodium channels, class 3 that will block the potassium channels, class 4 which will block the calcium channels. They're stupid, they missed 2. They did not. Class 2 are drugs that will target the heart as a globe. Everything within the heart will be targeted. What could be the perfect drug to do that? a beta blocker, right? A beta blocker could be able to block all these functionalities of the heart and affect the electrical conduction system at different levels, okay? So it will have a comprehensive antiarrhythmic property, okay? These are class 2 antiarrhythmics, beta blockers. Now, class 5 are, some people might not have class 5, but class 5 are miscellaneous drugs. Miscellaneous means that we're unable to identify the exact mechanism by which they cause the antiarrhythmic properties. So we group them into this group, and we try to have something like a speculative mechanism of action for these drugs. So it's not totally definitive. Let's start by class 1. And class 1 will be the drugs that target the sodium channel. Okay? The sodium channel. If they blocked the sodium channels, what could they affect within the ventricular action potential? The depolarization, which is what? Phase 0. What could they affect within the ECG waveform? The QRS complex. Okay? So if you block something, it means what? That the occurrence of that thing will be delayed or slowed at least. And that's why, if I show you the ventricular action potential curve, and I showed you phase 0, how should I represent a heart that has blocked fast sodium channels? Phase 0 will be what? More steep and more gradual, right? If I go to the ECG waveform, what should I notice? The QRS, instead of being this waveform that happens rapidly within a certain time limit, it's going to be what? Broadened or widened, okay? So this is the QRS complex after blocking the sodium channel. That's how we integrated the information. That's how you understand these things. Do not memorize. Just remember how the action potential works. We have fast sodium channels, it means phase 0. If I block that, instead of being abrupt, it's going to be more gradual. So there is what? Slowing of depolarization. And if phase 0 is represented by the QRS, when I block the sodium channels, the QRS complex will be widened. Okay? Fine. The question is, what's going to happen, for example, to the excitability of the ventricle or the ventricular muscle when I give a sodium channel blocker? مين حكى increase؟ واحد. مين حكى decrease؟ مين حكى no change؟ طيب مين حكى بالله increase؟ defend yourself. حطيت ايدك هون، محدش حكى. طيب, why do you think the excitability of the ventricular muscle will be less? Go ahead. Refractory period might be part of it, but don't forget, the refractory period is defined also by the phase 3. So there might be just a slow phase 0, but then the ventricular rhythm will go back, or the action potential will go back to the normal duration of refractory period. Exactly. Time-wise, and to get to the level where you could get the heart into a threshold and then to be excitable for the next round, it's going to be much slower. Okay? So the excitability of the muscle will be lower. And that's why in some textbooks, these drugs are called membrane stabilizing agents, membrane stabilizing antiarrhythmics, because the excitability of the ventricular muscle cell will be less. It's like they are stabilizing the muscle. Okay? So, the class 1, let's summarize. They lead to slowing of depolarization and conduction, decreased slope of phase 0, widening of the QRS complex, And because of these properties and the decrease in excitability of the cell, they are called membrane stabilizing agents. Now, something nice about these drugs is that they have some sort of differences in their degrees of blockade of the sodium channels and degrees of blockade of the conduction itself within the muscle. We have different classes. 1A considered the moderate ones, 1B has less blockade of the sodium channels, and 1C has more and more blockade of these channels. Why am I mentioning that? Because I'm gonna have or highlight one drug that's still in use currently. The other drugs are almost, let me say, disappearing in practice. The only drug we have is a drug that belongs to the 1B family or class or subclass of the class 1 antiarrhythmics, and that is lidocaine. You know, Muslim lidocaine in any kind of thing. مين بيلعب فوتبول؟ 16 معناته إذا بتلعبوش فوتبول معناته بتعزفوا تشيلو. ما بشوفوا البخاخ اللي بفكوه على. This is a local anesthetic, lidocaine, okay? But we have some properties of lidocaine that could qualify it to be used as an antiarrhythmic. And such qualities could be what? احنا بنحكي class 1 شو الميكانيزم؟ Blockade of sodium channels, okay? It's a class 1B, which means what? It has much less degree of blockade of these sodium channels. But something interesting about it, and this is the major feature that you have to know. And I need you to infer certain things out of this statement. Lidocaine rapidly associates and dissociates from sodium channels. Type. Rapidly associates and dissociates from sodium channel. So it comes to the sodium channel, block it, and then dissociate. Type. If I want to talk about the turnover of blockade, what could you describe it after lidocaine administration? Turnover of blockade will be so rapid. It just binds, it just dissociates. Binds and dissociates so quickly. Type. If the turnover is so rapid and the blockade turnover is so rapid, what's going to happen to the rate of depolarization? هلا حكينا احنا class 1 ideally they will have slowing of depolarization and increasing the slope or decreasing the slope, right? Type. If the turnover of blockade is so rapid, what's going to happen to the slowing of depolarization? It's not that much.
Yeah.
It just binds, blocks for a very minute time, and then dissociates, and so on. So that's why the rate of depolarization is not decreased that much. What? Huh? No, there is a decrease, but that's not too much. Okay? There is a little effect on the rate of depolarization after using lidocaine. طيب. الشغلة الثانية. حكينا إنه sodium channels have 3 phases. They're either open, inactivated, or closed. طيب. For a blocker that comes and binds so rapidly and dissociates so rapidly, which one of the channels will it like to bind to? The open. That's the first one. And it could have some bargain by binding to the inactivated. But it will not like to bind to the closed. يعني انتوا بتحكوا عن زلمه مهم. اوكي؟ ما عندوش وقت انه يروح يربط مع الكلوز، ليش بتربط مع الكلوز؟ Why would it like to bind to the closed channel? Right? So it would like to have some sort of prestige. Okay? I have too little time, so I'm going to bind to the most important types, which are the open and inactivated channels. Right. This is important. Why? What do you think? Where should I use lidocaine in? In a tachycardic heart, a normal, ما فيش normal. A bradycardic heart or a normal cardiac heart?
Tachycardia.
Tachycardic, why?
Because it's open.
Because the number of channels that will be
Open
open or inactivated will be much higher. It's again, at the turnover of the activation, inactivation of the sodium channels will be so quick, so fast. So if the rate is increased in a tachycardic heart, the number of these channels will be high, and that's where we use lidocaine. Type. The more the heart has open and inactivated channels, the more effect lidocaine will have, right? عشان هيك there is some sort or some term in anti-arrhythmic pharmacology books. They say lidocaine has the feature of use dependence. Which means what? يعني يا جماعة, I have a heart. The heart rate is 180, for example. I have given lidocaine, right? The rate will be what? Slower or decreased. الآن صار الرate, let's say 150. Okay? Will the effect of lidocaine be as much as it was at a 180 heart rate? No, because the number of the open and inactivated channels are less. Okay? If I go even to 100, the efficacy of lidocaine will be even much lower. Okay? This is called use dependence. Did you get these concepts? حكمي حكا احكي اي واحد منهم. Use dependence. As I'm saying, the effect of lidocaine is higher when we have a higher percentage of open or inactivated channels. And when does that happen? At high rates of the heart. Okay? Now, if I go to a lower rate, that's going to lead to what? Less efficacy of lidocaine, because the number or percentage of open or inactivated channels will be less, and efficacy will be less. To summarize, rapidly associates and dissociates. That means little effect on the rate of depolarization. There is a preference for open or inactivated channels. There is the feature of use dependence. And because of such features, we'd like to use lidocaine in ventricular arrhythmias. Okay? Then something to remember about lidocaine, which is maybe one of the not nice things about it, is that it has extensive first-pass hepatic effect. Okay? So is it given orally? Not at all. We never use it orally. We use it by IV injection. Okay? So the hepatic effect will be almost gone or less. Okay? But the thing is, you have to take care when you talk about what? People with hepatic dysfunction. You have to adjust the dose in these patients. فهمتوا يا اخوان؟ بدي فهم مش حفظ. فهمتوا الستوري؟ طيب واحد احكي. تقريبا ما سمعتش ولا حرف. Because the metabolism of lidocaine happens in the liver. Okay? So when you have a decreased metabolism, you have what? The dose of lidocaine will stay. The effective dose of lidocaine will stay in the blood. So you have to reduce the dose. Hey! أنا خلقي بسمعش. احكي. لأنه زي ما حكينا كلاس 1 صوديوم channels وبالتالي it will affect. مالك؟ Okay, so the major effect will be on the ventricular part or the depolarization, which is what? The QRS. Now the P wave, which represents the atrial depolarization, as you said, it could be also affected, but not that much. Okay? Like the potential or voltage of the P wave is not that reduced, okay, and not that widened, because most of the effect is on the fast sodium channels in the ventricles. you're thinking in the right way. Yes. لا هيعمل أكيد يعني. إحنا we mean if we have the effective dose set at 10, okay, مش هتروح ل 20. أكيد side effects and so on will be higher, even if the liver function is still normal. But what I meant is that if the liver function is reduced, okay, so the metabolism is reduced. Metabolism means turning the drug into an ineffective metabolite, okay? So that means a lot of the drug will stay in the effective form, and that might lead to much more effect than I desire. طيب, let's take مين كان بيسمعه؟ Little effect, because as we said that it rapidly associates and dissociates, okay? خلاص rapidly associates and dissociates from the fast sodium channel, okay? So it does not stay there for long, okay? The turnover is so rapid, so the effect on depolarization is less. If you have a drug that will block these channels for long, okay, the rate of depolarization will be too much decreased. Yes? It's important in other phases of the action potential. This is one. And the second thing is the excitability. هلا لما تحكي إنه which channel is more ready to be activated again? The closed or the inactivated?
Inactivated.
لا, inactivated. Because we have one pore that is open and one pore that is closed. So if I get rid of that pore, I'm going to get it activated again. So this is the term of excitability of the channel. لا فيش شيء موجود. طيب, خلينا نخلص this class and then you will take a break and come back for the next part. Class 2, which are the beta blocker. And in the beta blockers, as I said, are the drugs that will target the heart globally. So we're not affecting a particular ion channel within the heart. We're affecting the heart itself. طيب, what could be the effects? أول شيء, what type of receptor on the heart? Beta 1. Okay? So we'd like to use the selective beta 1 receptor blockers. This is the first part. The second thing, what could be the effects of a beta blocker on the heart? أول شيء, effect on the rate. The rate will be what? Reduced. What do you call this?
Bradycardia.
طيب, what do you call it in physiological terminology? Chronotropic effect, right? Is it negative ولا مش ماخدين واضح؟ Nice. طيب, انسوا هذول التيرمز بحكي لكم عنهم لما نخلص الكورس. بقى the rate, right? What else? The force of contraction will be reduced. Okay, what else? Conduction will be decreased also. Okay? So that's why we have a global effect on the heart, the rate, the force of contraction and the conduction. Okay? And that will lead to just reduction of the activity of the heart in general. Type. What kind of arrhythmias would you like to use beta blockers in? So let's say that first off, it should be an increased rate, a tachycardic arrhythmia. Okay? So what we say, these drugs are heart rate controlling antiarrhythmics. Most of the effect will be on the heart rate, okay, with some sort of effect on the conduction system and the contractility of the heart. And that's why the major use of them is in tachyarrhythmias. When there is an increase in the heart rate, you'd like to use the class 2. Okay? One particular and useful use for beta blockers, and you're going to have more discussions about this in the clinical lectures later next week, is post-MI. Since post-myocardial infarction, the heart is susceptible, certain parts of the heart are susceptible to abnormal rhythm and abnormal conduction and abnormal stuff. These patients are susceptible to ventricular tachyarrhythmias. Okay? And that's why beta blockers are something that's prescribed commonly post-MI, even if the patient does not have arrhythmia at the current time. One of the advantages of that is that we are having a prophylaxis against tachyarrhythmias. Okay? يلا فيعوا خذوا بريك على 10:15.